Good morning to everyone. I'm going to talk. My name is Jaime Aramberri, and I work private practice in Spain. I've been doing ICL implantation for 12 years, and I'm going to give a lecture of ICL sizing based on UBM measurements and some other anterior segment biometry parameters. So just an introduction. You all know that we've been sizing the ICLs from some anterior biometric measurements, mainly the horizontal corneal diameter and also the ACD. But it's been published, and we know right now that sulcus to sulcus size prediction, and this is our target, from white to white corneal distance and angle to angle ACD or other indirect parameters, lacks precision, as there is a low or no correlation at all sometimes with these variables. So we have regularly a 10 to 15% of unwanted low or high bold values, and we know that the worst ICL complications are related with this fact. So this is a main issue in improving our results with ICL. The only method that allows measuring beyond the iris barrier is ultrasound with the UBM. But we found, and we regularly are reported to be some problems with this. Mainly there is a long learning curve. Doing UBM measurements is not that easy. It's an uncomfortable procedure. Maybe this is the least important problem. And repeatability and reproducibility of measurements is not good. And it's not good even in good hands, and we've measured this. So my personal evolution of ICL sizing, the first years I used to do it with the white to white, with the STAAR software. Then I used to implement also the ACD for fine-tuning this measurement. Since 2006 I started using the UBM with the Bumax 2 of Sonomed, and I've been doing that for some years. And since 2010 I've changed it to the Quantel UBM compact touch unit, and I've been developing some regression formula to do it more scientifically. So this is the device I'm now regularly using, and this is the device I'm basing my calculations upon right now, and this is what I will present to you. And the most remarkable feature with the compact touch unit is that measurements are captured automatically only when 7 alignment criteria are met. And this is very interesting to ensure the user that measurements are reliable. So we quite trust the measurements at that certain angle you are placing the probe, because the software is self-detecting when these measurements are correctly aligned, and this gives you quite a good security. So we found in a previous work that the sulcus to sulcus repeatability was pretty good with a repeatability coefficient, and this is the maximum absolute error that will occur between 95% of per observations, was 0.4 millimeters, and the precision, the range to standard deviations up and down, was 0.29. So I have to say that this unit has itself in the software simulation software for the ICL. It's very beautiful, it's very graphic. You can input the ICL model, as you can see here, so that the software simulates the position of the lens. But unfortunately this is not accurate, so I really recommend you not to use it. But I mention it because there might be some confusion on this. So this software within the software of the device doesn't work. So the objective of this work was to analyze correlations between these parameters and develop a formula to improve ICL sizing. So this was the set of eyes that we recollected from October 2010 to August 2011, 104 eyes of 60 patients. It was the consecutive recollection of patients undergoing ICL surgery. So we did this parameter measurements, the sulcus to sulcus and the lens rise, and this is a very interesting parameter. This is the distance from the sulcus to sulcus plane to the anterior apex of the lens, and we've seen that this is a very relevant parameter for ICL sizing. And we did one first set of 10 measurements we edited manually the 10 echograms to correctly place the gates so that the software was correctly measuring the distances. We did another set of 10 measurements, and finally we did an averaging. So the final number is the average of 20 measurements. So you quite will trust that number that it's being get. So this is the sulcus to sulcus, and this is the rise. The rise is the distance, as I've told you, from the sulcus to sulcus plane to the apex of the lens. And I repeat, this is as important as the sulcus to sulcus. So we did the ACD with the ARPScan, and we did the horizontal wide to wide with the ARPScan. But take care of this. This is not the measurement by default of ARPScan, but we edited with the iMetrics, and we manually define what the horizontal wide to wide is. And normally it's around 0.25, 0.3 millimeters wider than what the ARPScan is telling you it is. So take care. This can be matched with what you get with a manual caliper. And post-operatively, we again measured the ICL bolt, the sulcus to sulcus, and the lens rise. And take care, normally these magnitudes are now bigger than pre-op. And this is because normally the ICL goes a little farther within the eye. So now the sulcus to sulcus is wider, and the rise is bigger. You will see it with some examples afterwards. So, well, I will go directly to this because this is the interesting set. This is the 95 myopic eyes that we used to calculate the formula. So you can see here the numbers. H was young. We had this spherical equivalent of the lens. And you can see that the sulcus to sulcus is a little smaller in mean than the wide to wide, and this is coincident with what has been published before. This is the mean rise, so the mean distance from the sulcus to sulcus plane to the apex of the lens is 0.71 millimeters, and the ACD, and you can see that distributions are quite normal. Well, I will overlook the hyperops. I will overlook this. So one classical question in this issue is there a correlation between the sulcus to sulcus distance and the wide to wide? In some papers there is, in some papers there is not. In my series there was, not a very big one, but there was a correlation. So the wider, the bigger the horizontal corneal diameter is, the bigger, the higher number you get for the sulcus to sulcus. And let's go to the bolt. This is the bolt we got, the actual bolt we got in this series. It was a 0.58 millimeters in mean, and you can see there is quite a wide dispersed set of data with a standard deviation of 0.27. So we got 2 eyes under 200 microns. We had 8 eyes over 1,000 microns, 1 millimeter, and there were 3 eyes over 1.2 millimeters. So there was, as you can see, the distribution is a little tail to the right involved. So this was interesting to see what occurred from the pre-op sulcus to sulcus to the post-op. And as I told you, there is an increase in size, and you might imagine this like the ICL, once implanted in the eye, expands, opens the sulcus to sulcus, because the pre-op sulcus to sulcus, the ciliary body might be attached to the pigmentary epithelium of the iris, so some part of the sulcus to sulcus might be hidden. And with the ICL footplate, you open up that sulcus to sulcus fornix, so you get a wider distance. And the rise increases from pre-op to post-op. How can you read this? Well, my interpretation for this is that the lens really gets implanted a little more posterior than what you measured as sulcus to sulcus preoperatively, and this is why the post-op sulcus to sulcus plane is more posterior than the pre-op sulcus to sulcus plane. And I repeat, it will be more easily seen in the examples I will show you afterwards. Well, this relationship, the measurement pre-op to the measurement post-op, I split it, separating the normal central eyes and the extreme eyes. And this is quite interesting because you can see that the small sulcus to sulcus became bigger. The normal, the central sulcus to sulcus remained central, and the bigger sulcus to sulcus went down a little bit. So there is a kind of centering of results, and this explains why not measuring the sulcus to sulcus, the way it's been doing the calculation of the ICLs, is not that bad, because finally they end up in a central zone. So this is why not measuring the sulcus to sulcus hasn't been that important, knowing that there is no correlation, or it's a weak correlation between the sulcus and sulcus and the white to white, if you know what I mean. So these are examples. You can see from pre-op to post-op, and as I told you, if we measure from here to here, and now we implant the lens, there is an opening of the fornix of the sulcus to sulcus, and this is why this measurement is 0.59 millimeters wider. And as I told you with the rise, look at this distance from the sulcus to sulcus to the apex of the lens. It has become bigger. In this case, 0.4 millimeters bigger. And this is because the lens gets more posterior than what we thought when we placed this gate over there. So really, if we want to try to mimic what will happen after surgery, we should have put this gate more posterior. But of course there is the ciliary body, so you put it here where you see the end of the sulcus to sulcus fornix. This is an example, for example, where there is a decrease in size. And of course this is because the lens maybe was a little shorter. And now we started doing the finding for the correlations, and we saw that the bolt was correlated to the ACD, to this parameter, which is the relation between the ICL size and the sulcus to sulcus, because when we do the correlation analysis, we cannot put into just the sulcus to sulcus, it must be related to what we implanted in, and the pre-op rise. And we did a regression analysis, and I tried 4 different formula, depending on how many variables I used as predicting variables. So you can see here just with the sulcus to sulcus, here adding the rise, here adding the ACD, and here adding the white to white distance. And we found out that the statistical significance was for these variables. And finally, in this calculating group, we got this, of course the mean error is 0, because the formula has been calculated in this group, and this was the median absolute error. And we saw that the best result was for formula 3, so from here on I will only talk about the formula 3, which from these results I decided was the best performing one. So you can see the distribution of both predictions. And this is compared to the real, this is compared to the real bolt. And of course, whenever you make a multivariable regression, you always get a more centered distribution. And the extreme of the distribution, the upper and lower part, gets out of what is being predicted. This is regularly happening with any prediction. And this is the prediction error. On the same group we did the calculation. So theoretically this means that this is the best result as possible we will ever get. And you can see that we can predict until 0.4 millimeters the 94% of cases, but still there are a set of outliers, and especially this one that is getting very, very away from the prediction. And the question, of course, is why. We see some examples. For example, this is a pre-ICL. This was a minus 12.5 with a 13.2 millimeter ICL in. And we can see that here we got a prediction error of 0.71, a very big one, just to address that that outlier that we were seeing before. And you might ask, and why did this occur? I don't know. This was just the real numbers of a real case. There is some variability, and unfortunately I have to tell you that even if you do this with so many cases, you still find some cases that get out of the prediction even in the same patient. And this is the right eye of one patient that was implanted with this lens, and we got a prediction error of 0.42 millimeters, a pretty big one. But the left eye, following the same way of calculating, of sizing the ICL, you can see here we were in the target. So why one eye was out of the target in such a big amount, and why the other one was in? Well, my opinion right now is that the technique of implantation might have an influence. Having seen these results from the last year to now, I'm being especially insistent when I implant the ICL in making a to and fro movement and a lateral movement to be sure that both foot plates are looking for the place and none of them is getting folded by any irregularity of the sulcus fornix. So I implant the lens, I put in the place, but after that I do a right and left movement and to and fro movement, up there, down the incision, so I make it sure that the lens is going well inside. And it might be coincidence, but since I'm doing like this, my results last year have been a little better, and you will see that now. For example, here we've got an asymmetric implantation, and we found out that the foot plate was more anterior, and this was a case again with a high prediction error of 0.41 millimeters. And this is very interesting because this is the last numbers I have calculated just before coming to this meeting, because this is another group. This is what I call the validation group. This research is still going on, but these are the first results for 57 eyes. And you can see that the demographics are very similar to the calculation group I have presented you before. So we are getting a very close sample to the one I calculated the ICL on. And these are the results on this validation group. We got the formula predicted a little higher bolt than what actually happened, around 0.1 millimeter, but the median absolute error was 0.13, very close to the 0.12 that we got in the calculation group. So we are really getting the very same results as we've seen before in this validation group that had nothing to see with the calculation one. And this is the cumulative frequency of the absolute error in prediction, and you can see that results are better than in the calculation group, because we don't have those outliers in the upper part. We don't have those 0.50 something millimeter, or even that 0.70 millimeter that we got as a big outlier. And with this formula in this validation group, we can tell that we've got the 100% under 0.4 millimeter of absolute error. And we can put the 92% under 0.3 millimeter error. And I think this is a quite good result if you translate this to the stepping of the ICLs, which is in 0.5 millimeters. So my conclusion is that, well, anatomical measurements with the UVM correlate with botth, and of course this is not surprising. The sulcus to sulcus size and the rise are the main predicting variables. We can add other biometric variables like the Y to wide or the ACD or maybe the H, but the main predictors remain the UVM measured variables. And a regression formula with these variables has an acceptable error in botth prediction, and I think this is a step forward in ICL sizing right now. My intention is to conclude this research. I want to compare these results with what STAAR software is calculating for me as a user, So just to make it sure which one performs better. And a question that is frequently done by users, which is, and if I move to the UBM, how many cases per year I'm saving from a bad result? And that this is the practical question, of course. And we'll know that when we finish this study that I'm intending to account for around 70 cases in the validation group. But I guess that there won't be much difference from what we've seen here. So, and this is all. Thank you very much for your attention. And if you have any questions.
So what do you think is the correlation of the anterior chamber depth involved? If you have a deeper anterior chamber?
Yeah.
Less fault?
Well, finally, what you are trying to predict is the whole size of the anterior segment somehow. And logically, we should think that the posterior magnitude of the sulcus to sulcus diameter should correlate with big pre-iris structures. So everything goes together. I mean, if you've got a wide angle-to-angle and a wide ACD, it sounds logical that the sulcus to sulcus should be wide as well. But when you do a numerical multivariable regression, you find out that the predictive power of the ACD is not that big. So even if I withdraw the ACD from the formula, results wouldn't have been very different. Why did I leave it there? Well, because I tried for formula and I saw that the predictive error with the ACD was just a tiny second decimal lower than not using it. So I kept it there. But I can tell you that it doesn't make a very big difference. Yeah.
So from the report, I understood that your formula is still under the construction, let's say. It is not yet finished.
Well, I will tell you what I will do. I will provide it, I will publish it as it is, so that any of you can use it. It's a very simple linear regression formula, so you can program it in Excel, or maybe STAAR could use it in their calculations. If they like my work, they will probably and very gently ask for me, and I might say yes. All right, I know.
Yeah, and the second part of the question is that, as I can understand, that the UBM is good for measurement, but you cannot count on the UBM software to size the IOL. So I have to measure it by UBM and then either to use your formula or to use a normal calculator.
All right, that's right. I mean, the Compact Touch has ICL simulation software, but I wanted to make it very clear that what I've been doing has nothing to do with that. And when we got the Compact Touch unit, the first thing we did was to see the predictability of that prediction formula they have implemented in, and it's not working. I mean, it's not working. So I would recommend it to not to use it. But I repeat, this formula I've calculated is a simple linear regression formula. You can program it in, once you see it in the paper, you can program it in Excel in 1 minute. So you've got your Excel with your formula, and you can do it yourself if you want, or maybe it's done by the provider.
Thank you.
All right. Any more questions?
Thank you.
All right. Thank you very much.